Hello to everybody, good night. I'm sorry for the delay. I'm very sorry for the delay. I've been having lots of trouble with this. I found this other laptop I'm using right now. But I could finally get to see you to give you the last session. Again, I apologize for the delay. This is one of my favorite sessions. Let me see. Do you all get to see the PowerPoint? Okay, here we go. Well, this is our final session. I hope you enjoy the course. Later on, you will be having access to all of the presentations. And as usual, if you have any doubts, questions, or you suggest anything else, I'm open to any suggestions to get this course better eventually. All right, so when we talk about acute abdomen, it's a common situation, and the only objective that I would have for you on this class is that you recognize the emergency of an acute abdomen, independently of the main diagnosis. You have to identify when an acute abdomen is set upon you. So, as a definition, it's a variety of serious, which could be non-traumatic or traumatic intra-abdominal pathologies that will mandate emergency operation or a major medical intervention, because not all of acute abdomens are necessarily surgical. Most of them are, but we have to recognize them when we see them and refer them eventually, refer them as soon as you can. And get the patient or the family, you have to let them know that this is a matter of life or death. So we have many causes, we have many etiologies accordingly. We have pathologies that are intra-abdominally speaking or extra-abdominal, such as kidneys or any other pathology that may simulate as an acute abdomen. And depending on the age, the background of the patient, medications, and so forth, we have to analyze this. The abdomen itself, it's some sort of a black box. We have no idea, and we are almost entirely blindly. What we have to trust, and we have to be very conscious about it and very thorough examination, is we have to make a good clinical chart, a good clinical history, and an excellent exploration, and therefore we can determine what sort of etiology are we dealing with. In abdominal causes, we have inflammatories, most of the cases. Of course, everything begins with inflammation. And then we have a variety of pathologies that can go either from a perforation or ischemic causes, hemorrhage, or in some of the cases, torsion. Torsion of almost anything, you name it, intestines, ovaries, the colon itself or the mesentery, anything can happen. Just imagine a black box, and we have parameters to guide us along the way. So this is it's not the presentation that matters. It's not how many books you read, but how many patients you get to see in acute abdomen and the fact that you suspect it. So how are you going to diagnose an acute abdomen? As long as you can see it. So if you get to inspect an abdomen, you always do that and determine if it has an acute pathology. Now, extra-abdominal, we're talking about retroperitoneal. We're talking here about kidneys, pancreas, or the abdominal wall, which is a rare instance, or all the causes, such as most of them traumatic. We're not going to get into that. We're going to see a few examples, but you have to get the main objective of this class is that you get an idea of what an acute abdomen is, and when you see one, I can assure you, you will never forget one. So as I told you earlier, you have to be very, very organized in your assessment. You have to be very thorough, and you have to suspect it even with mild symptoms or atypical symptoms. A third of the acute abdomen that are presented on the emergency department or even at the physician's office, they are diagnosed with a proper history and physical examination. Again, you don't need to go any further into laboratories or radiological imaging to make a diagnosis. You can suspect it with just an appropriate questioning and with a thorough physical examination. And then, pop up, you have your diagnosis. So these are some of the tips. According to the age, you will be thinking of one pathology more frequently than the other. Example, in the elderly people, it is more frequent that we find volumous, or even think of adenocarcinoma that is presenting, and the typical presentation of a cancer in the colon is by occlusion of the large intestine. Or another pathology on the Western society is often recurred as diverticulitis. These are false pouches in the walls of the intestine, and I mean false pouches because they don't contain the whole layers of the colon wall, but they get inflamed, and when they do, they can become ruptured, and we have to be very careful about this. When are you going to suspect this? Well, this is the typical old 50-year-old male that never eats any vegetables. He eats a lot of meat, a lot of carbohydrates, such as beans, black beans, or alcohol. I mean, you're going to suspect it because in a Western society, we cut off the fiber from natural sources, such as vegetables. So this is a small commercial. Try to eat a lot of vegetables in order to avoid this complication. And on adults, we talk about a variety of it as well. We don't think right away in cancer, but we think also in diverticulitis, cholecystitis, either men or female, and it is more frequent in females, or pancreatitis. Watch out for pancreatitis, especially when there's alcohol abuse. Now, in children, we think about other kind of pathologies. We don't think about diverticulitis or cancer right away. We think about infections of parasites, mainly. That's why it is so important that on every health campaign, we give them anti-parasites. We also may find appendicitis or another pathology which is very common in children. It is a mesenteric adenitis, and this is the lymph nodes in the mesenteric sheet. They become inflamed, and they simulate, or you can find them very similar to appendicitis. But the clue to find mesenteric adenitis is like the background that the child had previous cold symptoms like. So before the abdominal pain, before the abdominal pain, he presented with flu-like symptoms. In infants, we suspect intussusception. This is like the intestine gets wrapped in itself, and the key to find this in an infant is that he had a bloody diarrhea, and it looks like the gross aspect of it, and you have to ask, it is that it looks like a jelly, wet jelly species, or Meckel's diverticulum. And in the newborn, where you're not going to see this, but you're going to suspect that if the newborn becomes very intranquil and with a lot of anxiety, and is crying all the time, and he doesn't eat, and he gets vomiting all the time, you have to suspect of congenital hypertrophic pyloric stenosis. But you're not going to see this in an office. You're going to see this in a hospital. You have to suspect that in a hospital. So as you can see, the causes are very different, are widely different according to the age. So that's why you get to the diagnosis when you just with your questionnaire and your physical examination. Now, gender, this is very important because we don't get the same diseases, though we may find them equally, but there are some pathologies that are predominantly in one gender than in another. Sorry, I have to pause a little bit. Please wait, I'm having problems. Hold on a minute. Hello, I'm back. And after we talk about the gender, for example, in a female, it is quite common to find an acute abdomen due to cholecystitis. And we're talking about 4Fs. That is 4Fs that goes for female, fat, 40, or fertile, 40 and fertile. So if you see a woman that it is fat, that is around 30 to 40 years old, and it has an abdominal pain on the upper right quadrant, you can suspect it has cholecystitis. Or due to gynecological causes such as an ectopic pregnancy, you have to ask in women about their last period and whether they're pregnant or not. The other common cause to find an acute abdomen is when the ovary gets twisted, or with inflammatory pelvic disease, and you have to get some attention here in if the woman has any vaginal discharge. You have to ask or do semiology about the vaginal discharge, such as color, quantity, odor, and evolution in time. And male, we're talking about different things. It may be diverticulitis or volvulus according to the age, or cancer, or a perforated peptic ulcer. And here I will call your attention, always think about NSAIDs, about chronic take of NSAIDs such as naproxen, ibuprofen, because most people they take them like they're popping pills, like they cause no harm. But you see, one of the side effects of NSAIDs are they block the cyclooxygenase 1, and therefore we're inhibiting the prostaglandins. In the gastric section, where we're removing the protective barrier on the gastric chamber. Now, there are other causes that may make us direct our diagnosis, and this is what type of pain the patient is feeling. We're talking about visceral pain, parietal pain, or referred pain. That's why we ask if the pain is referred elsewhere. When we're talking about visceral pain, this is due to stretching of the fibers of the walls of a hollow disc, such as the stomach or intestine or colon. And this is very poor localized. If you ask the patient to point with one finger where he has the most pain, he or she cannot differentiate very well where the pain is located. And it occurs early during evolution. When we find parietal pain, that means the patient can actually point with one finger where he has pain. This is because the parietal peritoneum just got inflamed, and it is very acute. It is better localized, but it occurs late. Now, when you find this, the patient had already been about 12 hours on evolution, having started with the pain. And you may find some referred pain, and this is the felt pain away from the pathological region. And it is always ipsilateral, the same side of the involved organ. That means when you have an inflamed gallbladder, you may feel the pain on the back side, on the back right side of the body, on the scapula, the right scapula. And you divide the pain within quadrants just to guide you a little bit which organ may be involved, but this is not definitive. You also need to dig a little bit more on the history, such as what's the nature of the pain? Is it continuous? Is it colicky? Is it throbbing? Is it severe agonizing, like you feel like you're gonna die? Is it twisting or it burns? You have to guide the patient to tell you what nature is. And if it's due to other causes, you have to ask if he has vomiting, what kind of vomiting. Is he vomiting liquid or digested food or bilious or blood or intestinal? And when you find the intestinal, the patient, they say, I vomited just green. No yellowish green, but just green. Or fecal. And fecal, this warms you up to think about lower occlusion. Of course, you have to ask the frequency in order to find out if the patient is dehydrated, how many vomits, for how long, and the relationship with pain. Does it ease the pain after you vomited, or does it increase the pain? For example, pain precedes vomiting in appendicitis. This is quite common in infants and children, and also in pancreatitis, or in peptic ulcer disease. After vomiting, the pain eases. So after you find out about this, then you have to ask for associated features such as diarrhea or constipation. Does it have abdominal distension? And very important, you need to ask about urinary symptoms. And very important, medications. If the patient had any NSAIDs, they may be having the main pathology, or if the patient has been hospitalized recently because of this, or had any chronic disease or past surgeries. You need to ask about everything. And after that, you need to do this is something for you to remember. When you do the history, you need to focus on Socrates, and this is S-O-C-R-A-T-E-S, Socrates. I mean the site, onset, character, radiation, and the associated symptoms. The time course is very important, and you have to ask about factors which may worsen the pain or ease the pain, and always ask for severity. If you do this in this order, you will always be organized, and you will not left out anything. One example of this is you may guide yourself accordingly to think about some of the pathology that the patient must be having. And when you do this and you order some of the laboratories or radiology, you're almost 90% sure that that is your diagnosis. That is what is so very important. Now, when you do the physical examination, you have to see your patient if he has a facial pain, if he's yellow, or he's with great pallor, he's with great anxiety. Of course, you have to check for vital signs. And then the local inspection, it means just the abdomen. You have to look if it's distended, if when you touch the abdomen, does it hurt? Where does it hurt? Does it hurt just, it has hyperesthesia or hyperbaralgesia? And does it sound like a balloon when you make your percussion? And of course the auscultation. Now after that, you may find signs that will guide you to think of one pathology over the other, such as Collins sign, which is a common finding on pancreatitis or on hemorrhagic pancreatitis, or the Kerr sign, which is severe on the left shoulder plane, and it's indicative of splenic rupture. McBurney, this is typical of appendicitis. Morphy sign is typical on cholecystitis. All of these are found on appendicitis, and well, almost all of them, they tend to guide you over one pathology over the other, but they talk about acute abdomen. Now, this is the Morphy sign. You ask the patient to breathe in heavily, and when he breathes out, you press against his lower ribs, and he will even stop his breathing, his inspiratory sensation, and he will have a lot of pain. This is a Morphy sign positive. Of course, you see the rhapsody sign is when you push on the left lower quadrant, the patient will refer that he has pain on the opposite side. This is a positive for appendicitis. This is another sign for appendicitis. You extend the right leg of the patient on, he's located on his left side, and he will feel pain. After that, you can make almost any other sign, and this just indicates that it may be appendicitis, but in the end of the day, it tells you that he has parietal pain, and that is acute abdomen. So you have to find out why. You're already suspecting what. You make hematological blood count, electrolytes, biochemical, and this is in order to discard or refute what you're thinking. urine test. This is always useful, especially among women. And after, you do radiology. It depends where you are and what you need. If you're in a rural area, you're not going to have none of these, so you will have to rely entirely on your questionnaire and physical examination. Now, what kind of diagnosis you may have? You may have appendicitis. This typically presents with pain around the umbilical area, and then the pain migrates to the right lower quadrant, and then you will find any other sign. You may name it McBurney, Roxing, von Blumberg, iliopsoas, obturator, almost anything. This is quite important among children. First they vomit and then they feel the pain. And they never are hungry. And then you do your apparatus scale or score. This indicates that it is probably that the patient has appendicitis. And this is a way to remember it. It is called Mantrose. Okay, this is a migration of the pain, anorexia, nausea, tenderness, rebound pain, elevated temperature, leukocytosis, and shift to the left. As you can see, the tenderness in the right lower quadrant and leukocytosis, it almost realize that it has appendicitis. If you want to do laboratory, an ultrasound will be best, and you have to look at for this sign. It looks round, and it doesn't comprise the appendix at all. When you have this and it is larger than 6 millimeters, you have made yourself an accurate diagnosis of acute appendicitis. All right, let's move on forward. When you have cholecystitis, I told you the 4 F's. That means female, fat, 40, and they vomit. They have a very painful area on the right upper quadrant associated with ingestion of fat food, and they have pain, and they have the Murphy sign. If you find out the patient has Charcot's triad, which is jaundice, pain, and fever, watch out, because he has cholangitis. Okay, again, Charcot's triad means that you have fever, you have jaundice, and you have pain in the right upper quadrant, and this accounts for cholangitis, which is a very serious pathology. And you can confirm this entirely with an ultrasound, where you're going to find a thick wall of the gallbladder and the evidence, the stones. Intestinal obstruction, there's another pathology that can cause acute abdomen, and it is quite common and frequently. You're going to suspect this entirely of the background of having surgery before, because a patient that has been operated, abdominally speaking, operated, it forms adhesions, and adhesions tend to form the intestine to get kinked and gets obstructed. You're going to find out that the patient has vomiting, and the vomit, if it's in the upper extremity of the intestine, it's going to be early in its course. And if you're talking about on the large intestine, it may not have any vomit at all. You're going to find out distension. The greater the distension, the lower the place you're going to find out the occlusion. And after all, if it's in the colon, you're going to find out that the patient has absolute constipation. Other features, look out for dehydrated patients because they will develop renal failure, pre-renal failure due to lack of hydration. Be aware of toxemia. That means the patient is falling into hypovolemic shock. And be aware of the strangulation. You're going to find out he has acidosis, lactic acidosis. So he's going to be, you do this with a pH, measuring his arterial blood gas. Remember that? Be aware of that. If your patient has metabolic acidosis and acute abdomen, suspect strangulation. And, well, in this case, you're going to do a blood work, of course, or plain x-rays. And plain x-rays on occlusion, they can tell you a lot. What we look up in an x-ray is a gas pattern. And gas pattern, as you can see here, it looks terrible. And this is not supposed to look on a normal x-ray. You see these divisions, these are the connivence valves that they're not supposed to be seen on a normal x-ray. So this is a typical occlusion pattern. This patient needs to be operated right away. Here's another example. We call this like a stair, like a stairs pattern. As you see here, it looks like a pile of coins, right? And there's nothing here. There's no gas on the inferior abdomen. So this is also a typical occlusion X-ray. As you can see here, we can see the dilated loops, and these white lines, you're not supposed to see them on a normal X-ray. And this is the PK circularis, which accounts for connivent valves. You're not supposed to see again, all right? So if you see this is another typical occlusion X-ray. And this is another, right? This is what we call, when you see this cut off like a half moon, this is a typical of air fluid levels, and this is occlusion as well. And you see here like a pile of coins. It is the typical string of pearls indicating that the obstruction is mechanical. Here, you see here a lot of air fluid levels. This is a dilated septum. You see this connivent valves, and this is obstruction because of cancer. This is conjugated study. And then, see, this is volvulus. Looks like a grain of coffee. And, well, in case of pancreatitis, you're going to suspect this because the patient either has two things, either has gallbladder stones or is an alcoholic. So always suggest this. The patient will be presenting very ill with a pain that is way more severe than you may even imagine. It is located in epigastric, and it is referred to the back of the patient. And the patient, you will see him guarding, leaning forward, and he vomits a lot. You make an ultrasound. This is a normal pancreas. You see the head, the body, the tail over here. This is the artery, and here you can see inflamed the pancreas. Look at the tail over here. And to be more accurate, in case of the pancreas, you may perform a CT scan. As you can see here, the head, the tail, the head, the body, the tail over here, and this is a very ill pancreas. As you can hear, this is a contrastated study. You see the splenic artery and all of the fat around the pancreas. It is blurished. Another picture where you can see the head of the pancreas and the tail. All of these, look at these, all these very, the fatty area of the pancreas is dirty, and it looks like smashed. So this is a very, very serious pancreatitis. And if you suspect about perforated peptic ulcer, always check the history of NSAIDs. This is, as I told you before, this is very important for you to ask and suspect. They become very dehydrated, and they look like a wood. Their abdomen is like a piece of wood. And if you take an X-ray of the thorax, you will find air beneath the diaphragm. That means the air is leaking and going upward. What to do? Well, you can ask yourself, the patient is about to die, I need to rehydrate this patient and ask for help. If my patient is not going to die, but it can be stable for a couple of hours, I need to hurry and make an urgent diagnosis. If my patient it's in pain, but it's stable, I can do a proper investigation and do a quick diagnosis. And depending on this, you have to do the ABC, which is airway, breathing, and circulation. You have to put some analgesia. Not in the case of acute appendicitis. You have to monitor that patient, and of course, take the main cause as you find out. And that's pretty much it. After you find out the diagnosis, if it's surgical, it needs to have surgery right away, but you can do this in the meantime. You wait for the surgeon. Thank you. Thank you all for waiting. Are there any questions? Okay, I thank you all for being in this course. Thank you all for your patience this last week. I apologize once again, but I enjoy being with you. Thank you for your time. Thank you for being with me. And for whatever you want to ask further, or if you have any questions about anything at all, you know where to find me. Well, thank you all, and I will see you soon in the final exam. Bye-bye.